All this is Dr. Mubin Sayed, and with me, my favorite professional, medical professional, Dr. Paul Marik is with me. Dr. Paul Marik, welcome.
Thank you, my favorite bean, uh, the super cool bean of the world, Dr. Mobeen.
Thank you. Thank you so much. So the Dr. Paul Marik has been working for COVID, you know it all, for years. And now I feel so grateful and I am so blessed that this happened. What he did was he looked at, so for in the context of cancer, there are traditional therapies, plus there you must have heard anecdotes from your friends or people you know that, hey, somebody had cancer and they did this and this helped. So I used to always wonder that is there a piece of literature somewhere that can tell me what is really good and helpful and what is just snake oil sale, things. And Dr. Marik has done that. He went over about 1200 studies, weighted every study for the strength of it, clinical trial, uh, uh, randomized control trials, prospective studies, observation studies, weighted them, then pulled the best evidence out and brought that in the form of a list. I think this is a gold mine for all of us. So I'm going to stop and once again thank you, Dr. Marik, for doing this, and tell me, how do we present that to the audience?
Well, yeah, thanks. So obviously, cancer is an important subject. Most people, it touches them personally, either someone in the family, someone they know. And most people actually have a fear of getting cancer. And so what this does is to empower people so that there are things they can proactively do, firstly, to prevent getting cancer. And secondly, if they know somebody or they have cancer, that they can empower themselves to take control of their treatment. I think that's such an important thing that patients lose control these days. And so this is a way that it's just through knowledge and education and understanding is that I think the days of patients being, slaves to the medical system are over. Patients are equal participants and should participate in their care. And in order to participate, they need to be informed and educated. So what this document does is it's not a recipe on how to treat cancer, but rather it's a document that provides education, knowledge on some of the main issues that have to do with cancer and provides an approach to preventing cancer and someone who has cancer, how you can use the advice as adjunctive therapy. So this is not a replacement of conventional chemotherapy. It's important to stress this is used in parallel as adjunctive therapy. And indeed, it enhances, the data shows it enhances the clinical benefit of standard chemotherapy.
Excellent. Thank you so much. I am excited to discuss this. And just before we start presenting, just look at some of the comments. These are, so this is Cool Bean Lisu, this is Maro, Margaret is here. And so there are so many people who are so happy that you're here. So thank you. And I'm going to share
Yeah, and
this.
obviously thank you to the Cool Beans, because without the Cool Beans, we wouldn't be here.
That's true.
We're all part of the Bean family.
We are all cool beans. Cool. So, Cool Beans, thank you very much for being here. And Dr. Marik, here is the presentation.
Yeah, so basically, I'm going to be talking about the role of repurposed drugs and metabolic therapy for the management of cancer. Most importantly, I have no conflict of interest, and I think this is a really important point to stress, because even a small conflict of interest results in biased and unobjective assessment. But because I have no skin in the game, that I can look at the data objectively, scientifically, and be completely objective. So it shouldn't come as a surprise that the incidence of cancer is increasing quite dramatically. You can see over the last 20 years, the increased risk of cancer. And by 2030, it's expected that 1 in 3 people will have cancer. So despite the improvements in medical care and in screening, the incidence of cancer is going up. And as we'll discuss, there are really important reasons why this is happening. Most importantly, obesity, insulin resistance, processed foods, lack of vitamin D, vegetable oils, smoking, and alcohol. So this is essentially a disease of lifestyle. So because of the current Western lifestyle, incidence has gone up. And this slide basically shows the expected number of deaths amongst men and women this year. And you can see close to just over 300,000 men and close to 300,000 women are expected to die this year of cancer. And you can see the top players: lung, prostate, colon, pancreas, liver, and in women, lung, breast, colon, rectum, colorectal, and pancreas. And as we will discuss, these are not chemotherapy curable cancers. So the role of chemotherapy in all of these cancers is highly questionable in terms of curative therapy. And that's why adjunctive therapy with repurposed drugs and metabolic therapy is so important. Next.
Got it. And Dr. Marik, there is a question. Aaron Crane says, so 2030, 1 out of 3?
Yes. So it'll be probably 1 out of 3 people will develop cancer. So it's going to become the commonest cause of death in the next decade is going to be cancer, and it's going to surpass cardiovascular disease. So 1 in 3 people, close to 30% of the population, will develop cancer. So it is striking. And so this graph shows the increase in melanoma over the last 20 to 30 years. You can see the dramatic increase in the risk of melanoma, and this is the dramatic increase in non-melanoma skin cancer. And so this is not due to ultraviolet radiation. In fact, ultraviolet radiation protects against cancer. So there are fundamental lifestyle changes that have led to the increased risk of cancer. Next. So just the usual kind of disclaimer. So this is not intended as a standalone guide. It should be used as adjunctive therapy. And this is a living document. So our plan is to continuously update this document over time. And so it's going to be a living document. So this slide shows the traditional treatment of cancer, which is obviously, surgery, chemotherapy, and radiotherapy are the main pillars. And then you add bone marrow transplant and immunotherapy. Next slide. So there are problems with conventional chemo and radiotherapy, which many people don't understand. And that, as we'll see, the tumor is made up of many populations of tumor cells, and these are very heterogeneous. And so chemotherapy only targets the rapidly dividing cells. So only about 10% of cells within a tumor are actively dividing, and the cancer targets the dividing cells. Now, there are cells which we're going to talk about, stem cells. So these are the cells which actually give rise to the cancer cell. And these are slowly growing cells. They don't rapidly proliferate. And in fact, chemotherapy allows the stem cells to proliferate. We're then going to talk about the tumor microenvironment, which is really so important in maintaining the cancer. And as you'll see, chemotherapy increases inflammation in the tumor microenvironment, and it promotes the growth of the tumor. It increases angiogenesis, and angiogenesis is new blood vessel formation. And that's how the tumor cells metastases through these new blood vessels. And obviously we have increased metastatic potential because of the changes in the microenvironment and angiogenesis. And then not least, the chemotherapy is very toxic. It's myelotoxic. It's toxic to the bone marrow. It's toxic to the mucosa of the GI tract and the mouth. And of course, it's highly costly. Next. So the conventional theory of cancer. So the conventional theory is that cancer is caused by a genetic mutation or genetic instability. And this is really important because this is what most of the therapy is based on. this genetic mutation theory of cancer. And so it's assumed that because of this of these mutations gives rise to the 6 biological properties of cancer, which is sustained proliferative signaling. The cells evade growth suppressors. They resist cell death or apoptosis, enabling the cell's replicative immortality. So these cells live and complete and divide endlessly, induces angiogenesis and activates invasion and metastases. So this is the conventional theory. However, there are problems with this theory, and it's probably not correct. And so Otto Warburg was the very first person to come up with this concept, and really he is a pioneer in this area, and many of the therapies we're going to be talking about are built on his findings. So in 1927 he reported that cancer cells, and it's important to stress this is all cancer cells, it doesn't really matter what the type of cancer it is, they undergo anaerobic glycolysis. So these cells cannot utilize oxygen. They cannot utilize oxygen in the mitochondrion and electron transport chain. So the cancer cells generate energy through anaerobic glycolysis. And as such, because this is an inefficient mechanism, the cells are very dependent on glucose and are glucose hungry. And you'll see how important this concept is. And so this is known as the Warburg Effect, and he won the Nobel Prize in 1931 for this discovery. And it's important to emphasize that the Warburg Effect is characteristic of every tumor. Every tumor cell undergoes this Warburg Effect of anaerobic glycolysis. Next. And so building upon this theory of anaerobic glycolysis, Dr. Thomas Efried has basically pioneered the concept that cancer is a metabolic disease. It's not a genetic disease or chromosomal disease. It's primarily a metabolic disease. And so he is the pioneer in this area. He's written this book, which is really astonishing. He's published over 600 papers on this topic, and he provides convincing data. It's convincing that cancer is a metabolic disease and not a genetic or chromosomal disease. And because of this finding or this understanding, it obviously changes the concept you have of how to treat the disease as a metabolic disease and not a genetic or chromosomal disease.
Very interesting. So even if there are genetic or chromosomal or mitochondrial aspects, eventually they lead up to the metabolic disarray of the system.
Yes. So basically, you're right. So many of the cells do have genetic abnormalities, but what they're probably secondary to the primary underlying cause, which is mitochondrial and metabolic dysfunction. And if you actually, people have done really detailed genetic analyses, and there are no specific mutations which are characteristic of any tumor. Any single tumor, in fact, has many different mutations. And so there are some tumors that have no identifiable mutation. So it's likely that the genetic and chromosomal abnormalities are secondary to the metabolic disease. Now, there are some exceptions. For example, chronic lymphatic leukemia is due to a specific genetic mutation. It's a rearrangement of genes. It's called the Philadelphia chromosome. But that's one exception. Almost all other cancers, it's a metabolic disease. And so it's a metabolic and not a genetic disease. So this book by Travis Christofferson, Tripping Over the Truth, is a really excellent book. And he reviews the history of cancer. And basically what he says is no researcher can point to a single mutation or combination of mutations and say with confidence that it alone is the cause of cancer. And that's basically what I've said, and what he is emphasizing, that cancer is, any particular cancer, there's not a specific characteristic mutation. And he goes on to say, nor can researchers point to a series of cellular systems rendered dysfunctional by mutation and make the same claims. So he goes through this in quite detail, but probably the most important statement is the one below that. And this is by James Watson. People may not know who James Watson is. So he's Watson of Watson and Crick. Him and his colleague were the ones that discovered the structure of DNA and chromosomes. So I think they probably know more about DNA and chromosomes than anyone on this planet. And this is what he said in an op-ed. We may have to turn our main research focus away from decoding the genetic instructions behind cancer and towards understanding the metabolism within cancer cells. And so coming from James Watson, I think that's a profoundly powerful statement, and basically re-emphasizes that one has to rethink the way we think about cancer.
So, Dr. Marik, Lisu, she's a cool bean. She is kind of adding to your statement saying, I get it. It's truly astonishing. We actually have a t-shirt about this as well. So nice.
Yeah, it's truly astonishing. So just when you thought you knew everything about everything, it's astonishing to know that what you knew was probably wrong. Which happens in life, and it happens in medicine. And so that's why it's a journey. It's a journey of scientific discovery. So Lisa's right. So we now talk about the tumor environment, microenvironment. It's so important. And, it was a topic I knew very little about until I started digging into this topic. So the tumor cells grow in this microenvironment. It's the milieu, it's the environment in which they grow and thrive. And there are a number of cells called myeloid-derived stem cells, T regulatory cells, tumor-associated macrophages, and platelets. And then these are counterbalanced by natural killer cells and cytotoxic T cells, which tend to kill the cells, whereas the above cells tend to promote the growth of the cell and to decrease the immune system ability to get rid of the cells. Next. So this is a illustration courtesy of Dr. Drbeen, I must thank him, basically showing the tumor microenvironment. So in red, you see the tumor cells, but amongst the tumor are these myeloid-deprived suppressor cells, the Treg cells, the platelets, and these cells tend to support the growth of the tumor cell. And then you have your cytotoxic T cells, which mount an immune response to kill the tumor cells. But these Tregs downregulate the immune system. So you have this ongoing battle between these different cells in this microenvironment. The bottom line is the microenvironment tends to promote the growth of these tumor cells. Next. And then we have the cancer stem cell, which is so important. And this is something that many physicians don't understand and many patients don't understand. So you have the cancer stem cells. So these are the cells which grow and give rise to the cancer. So what happens with chemotherapy is chemotherapy targets the tree or the rapidly dividing cells, but they leave the roots untouched. So it's like pruning a tree. Giving chemotherapy is pruning a tree because it doesn't touch the cancer cells and in fact allows the cancer cells to proliferate. So it's obvious that when you treat a patient with cancer, you want to target the rapidly dividing cells, the tree, but absolutely essential that at the same time you target the stem cells. And that's what the importance is of repurposed drugs, because as we'll see, all of the repurposed drugs that we recommend all target the stem cells, whereas conventional chemotherapy only targets the rapidly dividing cells. So it obviously makes sense to use both. And then when we come to cancers are preventable, as I said, that lifestyle change or changes in lifestyle are largely responsible for the increasing risk of cancer. And probably the most important is insulin resistance. 40% of all cancers is thought are due to insulin resistance. And insulin resistance by a number of mechanisms promotes cancer cell growth. So insulin is a hormone, it's a growth factor. So it promotes the tumor growth, it prevents apoptosis, it promotes the tumor microenvironment. And at the same time, insulin resistance results in high blood glucose. And as we saw from the Warburg effect, the high glucose promotes the growth of the tumor cell. So insulin resistance is so important. And then obviously smoking and alcohol. We're going to talk about vitamin D deficiency, of which is overwhelming evidence that is an important risk factor for developing cancer. Processed foods in and of itself, and Dr. Bean talks about the famous lecture on processed foods, where processed foods in themselves causes increase in blood glucose, which then causes insulin resistance. But processed foods themselves can damage the pancreas through reactive oxygen species, resulting in insulin release. This is the famous lecture, or which Dr. Bean talks about. And then we know that sugary drinks, which cause spike in blood glucose and spike in insulin, cause cancer, as well as pure fruit juices. So you want to avoid these. You want to get exercise, aerobic and anaerobic. Stress is really important. There's a strong relationship between stress, quality of sleep, and getting cancer. So there are many things people can do to reduce their risk. And so this next study is a really important study. Dr. Bean talks about it in one of his more recent Dr. Bean series. So this was an interventional prospective randomized study, really important. This is the gold standard, in which there were 3 interventions. Independent, separately and together, the patients got vitamin D, and it was pretty low dose. I think it was like 2,000 units a day, omega-3 fatty acids, 1 gram a day, again, very low dose, and a simple home exercise program. And then what they showed is vitamin D, omega-3, and the simple home exercise program, each on their own tended to reduce the risk of cancer, but it wasn't statistically significant. When you added 2 of them, it became more significant, 2 of them together. But then when you added vitamin D, omega-3 fatty acids, and the simple home exercise program, there was a significant and highly statistical reduction in the risk of getting cancer. And you can see the hazard ratio is 0.39 or close to 0.4, which is a 60% reduction. So it's truly astonishing that using 3 simple interventions, these patients were able to reduce their risk of cancer by 60%. And so based on this data, there's not a single person on this planet who shouldn't be using these interventions, because who wants to get cancer? And you can significantly reduce your risk.
Absolutely. And I wanted to add one more thing. This study, Dr. Marik, you actually are the one who used it, and then I went and read it. This study is in 70 plus, where the risks of cancers and chronic diseases and inflammatory diseases increase. So even in 70 plus, doing these 3 simple things reduce the risk of cancers by 60%. That is astonishing.
And then obviously, the earlier you do it, the more beneficial the effect. So, you don't want to wait until you're 70. You want to start doing it now. And so you can see this was published in 2022 in a really highly regarded peer-reviewed journal. And so despite this data, nobody's talking about it. You would imagine that the media would have picked up on this. These are cheap repurposed drugs which could reduce your risk of cancer. And it seems like many of the other papers we're going to talk about, this literature is hidden. So this is our little protocol on reducing your risk of cancer. And you don't need all of them, but depends also on your baseline risk, that if you've had a previous cancer, if you have a family history of cancer, that you may want to be more aggressive. So vitamin D, omega-3 fatty acids, green tea supplement, green tea catechols, melatonin, very powerful in preventing cancer, and then metformin. And so the first 4 are over the counter. So those would be what we would recommend. If you're at a particularly high risk of getting cancer, a strong family history, then we would recommend adding metformin, for which you do require a prescription. So we're going to talk about as Dr. Bean said, I reviewed over 1,200 papers, and we stratified them according to their clinical impact. And so what I did use was prospectively was a stratification system to develop a hierarchy of evidence. And so this is what it's based on. So at the highest level is a meta-analysis of observational and or randomized studies. So you can see that prospective observational studies and randomized studies are given equal weight. And again, RCTs and observational studies, and then epidemiological studies, and then case reports and case series. So this is important because this is clinical data. And then beneath this level, at a lower level, we have in vitro, which is in a test tube, and in vivo, which are clinical models. So there are both in vitro and in vivo models that show that the repurposed drug kills the cancer cell, it kills the stem cell, it acts synergistically with chemotherapeutic drugs, and has an effect on the microenvironment. But the important point is that in and of itself, this is not sufficient evidence. You do need clinical data. We do need, if a repurposed drug or nutraceutical is effective in treating patients with cancer, then there will be clinical data. And so it's very difficult to make recommendations just based on experimental data. We do need real life clinical data. Next.
And sorry, just a quick comment. I can vouch for this, that when Dr. Marik was going over this monograph that he wrote and the protocols that are here, he was looking at studies and discussing that, hey, I'm going to number them, I'm going to weight them, and the weightage has to be for the strongest clinical evidence. So it is actually interesting to pick up the monograph, the document that Dr. Marik prepared, and look at the references and look at the strength of the data in those references. It is as you have other mainstream drugs, and there are references and evidences behind them. That is how the references are for these ones. So thank you very much for doing this, Dr. Marik.
Yeah, and so it becomes an important point, because if you're a practitioner that uses a particular therapy, whether you're an oncologist, you're going to prescribe chemo. If you're a surgeon, you're going to operate. If you are a holistic person, you may use low-dose naltrexone. And so, depending on the tools you have in your toolkit, the world may, if you're a hammer, the world looks like a nail. And so this is a really important concept, because people have said to me, well, what about low-dose naltrexone? And so, yes, they're correct. There is some in vitro and in vivo data showing the benefit of low-dose naltrexone. However, if you look at the clinical data, it's very scant. There are 2 poor case reports. So, if you prescribe naltrexone for, chronic inflammatory disease, it certainly doesn't mean that it has a role in cancer. And as we'll see, it actually ranks pretty low down. So it's really important to use the strongest evidence and looking at the way we've stratified it. So next slide. So basically what we did is we stratified the top 20 interventions and repurposed drugs. These are the top 10, because I think these are the most important and for which there's the most evidence. And so number 1 is a low carbohydrate, high fat, ketogenic diet. And so this is because, as we'll see, glucose is what drives the tumor cell. And so the data is overwhelming. Although most oncologists think that diet and nutrition has no role to play, unfortunately, they are completely wrong. And so the tumor cells, Dr. Warburg, Professor Warburg, discovered this in 1927. So we've known this for a long time. Tumor cells are highly dependent on glucose. And then we have green tea catechols. We have melatonin, vitamin D3. The data supporting vitamin D3 is overwhelming. It's not just randomized studies, it's meta-analyses of randomized controlled trials. And in patients with cancer, you really want to target a high vitamin D level, close to 100 nanograms per mole. And this is actually quite a safe level. You can even push it to 150. It's only when the vitamin D level gets to about 250 are you worried about toxicity. And then metformin, curcumin, which is a truly wonderful drug. It has so many numerous mechanisms of action in patients with cancer and supported by many clinical studies. Mebendazole, which is an antiparasitic drug which prevents the cell dividing, very good data. Omega-3 fatty acids, our favorite berberine, and then of course exercise, which is a combination of aerobic and anaerobic exercise and stress reduction. So this is the list of the top 10. And so we recommend that patients with cancer, they can select out the top 5 or 6 in this list according to their lifestyle preferences. The ones in red are the ones which require a prescription. So you can see many of these interventions, the patients can do without a prescription. And so we're back to the Warburg phenomenon, which is really so important. So you see on the left of the screen is a normal cell in which it uses glucose, goes through anaerobic metabolism, and then goes through mitochondrial respiration to make ATP. So this is a normal cell. A cancer cell...
Aerobic respiration.
Yes. Anaerobic glycolysis. Aerobic glycolysis. The cancer cell, on the other hand, because of the Warburg effect, cannot utilize oxygen through the mitochondrial electron transport chain. So it's highly dependent on glucose. In addition, what is fascinating, normal cells can use ketones as a source of energy. Cancer cells actually can't use ketones. In fact, ketones inhibit the growth of cancer cells. So they inhibit cancer cells. So cancer cells are highly dependent on glucose as a source of fuel. And that's why metabolic treatment is just so important, because it starves the cancer cell of its nutrients, glucose. Next. So this is the premise of Jane McClellan. So she was a therapist, a occupational therapist who developed metastatic cervical cancer. She was told she wasn't going to survive. She didn't accept that prognosis. So she basically did research and treated herself with a number of repurposed drugs. And she's written this book, How to Starve Cancer. So basically starving cancer. And then this dovetails really nicely with Dr. Siegfried's book, Cancer is a Metabolic Disease. Next. So basically what you want to do is you want to flatten your glucose curve. So if you have a sugary drink or pure fruit juice, you get a spike in blood glucose, which feeds the tumor cell. It provides nutrition to the cell. At the same time, it causes insulin release. And the insulin, again, potentiates the growth of the tumor microenvironment, the angiogenesis. So you can see why glucose management is such a vitally important concept in patients with cancer. You really need to flatten the curve. So you don't have these glucose spikes which feed the cancer, and you don't have these spikes of insulin. Next. And so this is really well demonstrated in the study published in the Journal of the National Cancer Institute. So this is in a highly prestigious, peer-reviewed medical journal. And so, if people question that nutrition has no role, well, in the oncology literature itself, it strongly contradicts that statement. And so the title of this article is Dietary Insulin Load and Cancer Recurrence and Survival in Patients with Stage 3 Colon Cancer. Now, what they found is patients with resected Stage 3 colon cancer who had a high insulinogenic diet were at a much higher risk of tumor recurrence and mortality. So again, profoundly demonstrating that high blood glucose with high insulin levels in this study increased the risk of tumor recurrence and dying from cancer. So I think it's no longer possible for any reputable oncologist to say that diet and nutrition therapy has no role in patients with cancer. I think this is a very important validating study. And then we get to chemotherapy. So chemotherapy does have a role, particularly in certain types of cancers, as we'll see. There are over 50 different chemotherapeutic drugs which belong to different cancers. Now, what's most important, as we said, they only target the actively dividing cells. And so that, there are various groups that are antimetabolites or alkylating agents or mitotic spindle inhibitors, but generally these chemotherapeutic drugs target actively dividing cells. Next.
So, Dr. Marik, a quick question. Lisu says, Finland recommends eating raw veggies that statin with color like beets, carrots, blueberries, tomatoes. Your opinion?
Yeah, so I think this raw vegetables are really good. Spinach, broccoli, carrots are okay. We don't recommend potatoes just because of their high carbohydrate load. But raw vegetables, absolutely. Specifically the green leafy vegetables, particularly the cruciferous vegetables, are absolutely very effective in limiting the risk of cancer, and obviously play a role in patients with cancer.
Thank you. One more question. Then we'll continue. VV says, for stage 4 cancer patients, cachexia caused by cancer or chemotherapy, any way to reverse the process? Once again, these are educational discussions, not medical advices. But here is the question.
Yeah, so we actually addressed the question of cancer cachexia. So it's a really good question. And so cancer cachexia is a really important problem. Basically, it's a loss of body weight and lean body mass in patients with cancer. And so it does have significant morbidities. And so in those patients, we don't recommend intermittent fasting. We recommend, a real food, a diet composed of real food. And we've discussed what real food is. Omega-3 fatty acids actually play an important role in attenuating the cancer cachexia. And then what we would recommend on top of that is, special nutritional shakes that are have are highly nutritionally of high nutritional value to treat cancer cachexia. So yes, it is an important problem. There aren't any drugs specifically which reverse it. It's a matter of treating the underlying cancer and then optimizing nutrition.
Two more quick questions. One, KC says, would you please share these slides?
Absolutely. So, Dr. Bean can share them with anybody who wants these slides. I would be happy to share them.
Thank you. Lonnie says, with glucose management, how are vital nutrients given? More vegetables, ? Or supplements? Does the book you mentioned cover this?
Yeah, so the book, which is really a monograph and a book, does go into this in enormous detail. So basically, you want to avoid processed foods. So if it looks like food, it's food. If it comes in a box, has a wrapper, has a label, it's not real food, it's processed foods. And so processed foods are what cause these high spikes in blood glucose. So if you eat real food, particularly leafy vegetables is really important, but protein as well, you can have a flat glucose curve. It's really the processed food, it's the processed drinks, it's the shakes, it's the sugary drinks that cause the glucose spikes. So yes, more vegetables, protein, and limited carbohydrates and limited intake of processed foods. And obviously omega-3 fatty acids already have numerous mechanism of action. The one obviously is the anti-inflammatory, and they increase the levels of, as this person says, resolvins and protectins, which actually are useful in the tumor microenvironment. So it appears that there's no question of doubt that omega-3 fatty acids actually do not increase the risk, they decrease the risk. And it's through probably through the microenvironment that decreased inflammation, as well as changing the lipid structure of the cell membrane.
Yeah, got it. Thank you very much. So we were here. Next slide is here.
So, obviously, traditional chemotherapy fails for many patients with solid tumors. And as we've said, solid tumors are composed of a heterogeneous population of cells, many of which are slow growing. So the cancer, the chemotherapy is not going to target these cells. And as I said, most of these cells are in the rest phase, so chemo leaves them alone. And then chemotherapy does not improve the cancer microenvironment. In fact, it actually makes it worse by promoting inflammation, which so that's why omega-3s, vitamin D, quercetin, green tea are really very helpful because they're anti-inflammatory, and they increase the immunity, and they decrease inflammation. And so again, chemotherapy enhances rather than kills cancer stem cells. And then with time, the cancer cells become resistant to chemotherapy. So for multiple reasons, we can see why chemotherapy fails. Next slide. So this slide contrasts standard chemotherapy with repurposed drugs. You can see, as we've spoken about, they target different cell populations. They affect on stem cells. They affect on adaptive immunity. So we know that chemotherapy suppresses the bone marrow. It targets the bone marrow. It causes profound immune suppression. And you need the immune system to act together with the host's immune response to get rid of the cancer cell. So in a way, by suppressing the immune system, you're just enhancing tumor growth. Again, the effect
just a quick note, my apologies. So if the audience are wondering why does chemotherapy suppress the immune system, shouldn't we have the immune system to go and attack the cancers? So what happens is that when you are giving the chemotherapy, most of the chemotherapy or usual chemotherapy tries to stop these cells from dividing, assuming that the dividing cells are cancer cells. So when we are trying to stop the cancer from dividing, in that process, other dividing cells of the body stop dividing as well. That is bone marrow cells making blood, the skin cells making skin, GIT cells making GIT surfaces, and immune cells, which are part of the bone marrow production. So this is an accidental outcome, but a very important outcome, because now we have a lesser effective immune system. Sorry, back to you, Dr. Marik.
Yeah, no, you're absolutely right, is that it seems contradictory that chemotherapy suppresses the immune system, which you actually need to kill the cancer cell, whereas all of the repurposed drugs enhance the adaptive and cell-mediated immunity. And then, of course, there's the severe toxicity related to chemotherapy. And then most importantly, the cost. The average cost is over $100,000 per year for chemotherapy. So the costs are enormous, whereas those are repurposed drugs. These are cheap repurposed drugs that are highly cost effective. And then, so when one talks of chemo, it's really important to realize that there are some cancers that are chemotherapy curable. And this is an important concept. So if you have one of these cancers, choriocarcinoma, lymphatic leukemia, promyelocytic leukemia, testicular cancer, much like the famous cyclist, germ cell tumors, Hodgkin's or non-Hodgkin's, these tumors are highly curable with chemo. So therefore, if you have one of these cancers, it's really important that you don't dismiss the value of chemotherapy. There are this group of cancers, breast cancer, ovarian, AML, in which chemotherapy does somewhat improve survival, that's length of survival or disease-free period, but it does come at a cost. And then there are those cancers which chemotherapy really has very little role to play, because it only provides some palliation. It doesn't improve survival. And this is a list of those cancers. So if you look at the role of chemotherapy and repurposed drugs, at the one end you have cancer, which is curable with chemo, and then the palliative drugs. So it makes sense that chemotherapy, the importance of chemotherapy diminishes with the spectrum as the tumor becomes more less responsive. And obviously repurposed drugs have an important role in all phases, but particularly as the chemotherapy becomes less effective. And then obviously there's surgery. So if you have a surgically resectable disease, and so that means that it's a local disease in which the malignancy is confined entirely to the organ and can be resected curatively, then the survival is really good. So if you have breast, prostate, thyroid, or melanoma of the skin, and it's entirely surgically resectable with no evidence of lymph node or metastatic spread, the survival is really good. So what we're saying is that surgery has a role, but in a limited number of patients and circumstances. Chemotherapy has a role, but repurposed drugs and metabolic therapy basically has a role across the spectrum. So therefore, what we're saying is the management of cancer must be personalized. The repurposed drugs and metabolic therapy really are the cornerstone of treatment. And then depending on the type of cancer and how far it's extended, one would consider chemotherapy, surgery, and then, of course, adjunctive measures such as stress management and sleep. And so, the monograph is now available on our website. You can go to flccc.net, go to medical evidence, and then under the reviews and monographs, you can download the cancer care monograph, and you can actually also download this set of slides, which should be available. So Dr. Syed will make these slides available, but it's also downloadable. And so, does your cat have any questions? I'm not. She's a very, very inquisitive cat. Does the cat have any questions?
It looks like she has questions for her own future health. So she's Kyrie. Luffy's sitting somewhere outside. Dr. Marik, this is, once again, I'm completely impressed. I'm impressed with your work that you did before for COVID. This is such a thorough work. And I would actually encourage the viewers to look at this cancer care and then look at the evidence there and go and read the studies by yourself as well, just to see that how strong that evidence is. I think that you'll be impressed as well. With this, I have a few questions here from the Cool Beans. So if you can give us another 5-10 minutes.
Sure.
Okay, excellent. So I'm going to start from Berku Kori, if I'm pronouncing the name correctly. Does taking too many antioxidants result in pro-oxidative processes, inhibit ferroptosis, etc.?
So that's a really good question. So many of the mechanisms, so radiotherapy and chemotherapy largely act by causing oxidant injury to the cell and causing cell death. So if you're receiving chemo or radiation therapy and you're taking an antioxidant, you can actually decrease the efficacy of your chemotherapy and radiotherapy. That's a really important point. And so you actually want to avoid vitamin C, N-acetylcysteine, coenzyme Q, if you are actually getting chemo or radiation therapy. And it's important to note that vitamin C in the low doses we use, or the orally doses, actually is a potent antioxidant. It's only when you give high doses of IV, of vitamin C intravenously, then it paradoxically acts as a pro-oxidant, killing cancer cells. So it's the oxidant injury which actually kills cancer cells. So makes no sense to take antioxidants in patients who are being treated for cancer. So low dose, so oral vitamin C, N-acetylcysteine actually should be avoided.
Got it. Thank you very much.
Question. Yes.
Yes. LDJT says, so we need more T regulatory cell in autoimmune disorders, but less of them for cancer?
Yes, so a Treg downregulates the immune system. So it inhibits the cytotoxic T cells and the natural killer cells. So you need the cytotoxic T cells and the killer cells to kill the cancer cell. And so Tregs downregulate them. So you're completely correct that autoimmune diseases and cancer are different ends of the spectrum. So the too many Tregs in patients with cancer. So you actually want to change the balance more towards cytotoxic cells and natural killer cells and less Tregs.
Got it. Thank you very much. Lonnie says, would this approach help get rid of other tumors such as desmoid tumors? Once again, no medical advice, but just educational discussions.
Yeah, so this would apply. This would apply to polyps. So there's a lot of data in patients with uh, polyps of the GI tract, which are precursors of cancer. And so many of these interventions are actually have been used successfully in patients with polyps. So if a patient's had a polyp removed, you are at a greater risk of recurrent polyps and cancer of the colon. So that's why interventions such as vitamin D, omega-3 fatty acids are really important to prevent cancer.
Thank you very much. Sorin says, recommend clinics in Europe for metabolic approach.
So I think that becomes a difficult question. I think what you need to do in your own area is to basically go to Dr. Google and see if you can find an integrative oncologist, but more likely an integrative primary care doctor who can help you on this journey. There are many things you can do alone, but I think it's much better if you under medical advice and you have a informed physician who can guide you along the way. And so, so what I would recommend is, to find a integrative primary care doctor or an oncologist who can help you. Unfortunately, most oncologists want to give chemotherapy, and so this is very threatening to them, and so they may not oblige. The question is, any specific nanocurcumin? I think they're all fine. The problem with curcumin is that its bioavailability is quite low, so that one needs to use one of these nano formulations to improve the bioavailability of curcumin.
Excellent. So with this, thank you so much. Old School says, Dr. Marik, this is so uplifting to hear. Margaret says, wonderful job. Alima is saying, thank you, Dr. Marik and Dr. Bean. This is, this truly is an important work. What I have seen is that there are various books, as you have shown as well. They all have a certain direction in which they move. However, collecting that, all of the data from various books, various studies, and then putting them together to be able to provide a helpful place to see what kind of intervention may have what kind of evidence and what are the top interventions. This was never done before. So thank you.
So what I did is obviously it took a lot of time and effort, but I kind of tried to reconcile and put all the data together in a simple format. And so it is available for download. And the good news is that we will have a Kindle version and a book version available within the few months. But please download the monograph and share it with your friends and family, and anyone who may have cancer.
So thank you so much. Thank you for your time. Thank you for this work, and thank you for joining us and sharing this.
And thank you for inviting me, and thank you for being King Bean. Thank you.
Thank you very much. So we have King Bean here. We have Emperor Bean here as well. So we have multiple kings here today. So thank you very much. And I would see you. I'll talk to you on Monday. Cool Beans, thank you very much. We'll have one more talk today. And Dr. Marik, this might actually be interesting for you. I had already had Dr. J.P. Salibi, for 6 o'clock. So today we have you and then Dr. J.P. Salibi as well. Cool. So with this, thank you very much. And I would see you all again. Bye for now.